thank Lesego for asking me to do this talk, and to AbbVie for sponsoring this talk. So thank you so much. I am a pediatrician, but I started treating kids 25, 26 years ago. So my children have all grown up. So I'm still treating a lot of them. They won't refuse to leave me. I don't know why. So I've had to learn to deal with treatment failure, obviously starting with when we did in those days, we had a lot of treatment failure. So apart from being a pediatrician, I do have a lot of experience with managing patients with treatment failure, both children and adults. Okay, so let's just a general approach to a patient who's failing. I think that's, if you have the approach, it's much easier, than just blindly, just what do I do? If patient's failing, high viral load, what do I do? So let me take you through this. Okay, there's my disclosures. So there are many reasons for changing regimen, but we are going to focus today on changing for treatment failure. And treatment failure can be either virological, meaning the viral load goes up, immunological, the CD4 goes down, or clinical, the patient gets sick. It's as simple as that. Why do people fail their regimens? Well, today, as previously, the vast majority are failing because they're not taking their treatment. Now, it's very important to realize that not taking your treatment may or may not mean there is viral resistance. Some regimens become resistant very easily. We'll talk about them. In that case, even if they do take the treatment, it's not going to work, but others take a long time to become resistant. And so often, just as pure adherence, if you can get them to take the regimen, it will still work. So adherence may or may not lead to resistance. If it's a mother or child, PMTCT can, of course, cause resistance. Then there's a group, small but very important group, where they are taking their treatment, but they are not working. For example, a malabsorption problem. A child that's growing and no one's increased dosages. Increased metabolism, also a pediatric issue, and drug-drug interactions, very important. Certainly in the third-line committee, in pediatrics, we're dealing with hundreds of children who are on third line because of the interaction between rifampicin and lopinavir. Okay, and because of that, they're ending up needing third line because it causes PR resistance. With our dolutegravir regimen, remember you've got all these drug interactions, things like calcium, magnesium, iron, the polyvalent cations, which reduce absorption. TB treatment, rifampicin, can also reduce absorption. So those are things that are going to cause resistance in dolutegravir as well. So it's a very important group. And the last one, transmitted resistance, that's where a patient gets HIV for the first time. They've never had it before, and yet they end up with resistance because they've picked up a resistant strain from the person that they got it from. Okay, and obviously we have surveillance to watch that, and that's one of the prime reasons why we changed our regimen, our first-line regimen in this country, from an efavirenz regimen to a dolutegravir regimen, because our transmitted resistance, or our pre-treatment resistance to efavirenz, was over the WHO cutoff of 10%, and that's why we changed the regimen. I just noticed that Amanda Koza has joined us from AbbVie, just to thank her and her company for sponsoring this, and really appreciate the sponsorship that AbbVie has been given. Okay, so let's do a poll. Get you into the mood. I'm going to launch it now. Right, truth or myth? Which of these, it's a multiple choice, which of these can cause a high viral load? Having sex without a condom, stress, eating unhealthily, or not taking ARVs regularly? Interesting, Lesego. Give it a few.
Very interesting.
Interesting, eh?
Yep.
Okay. All right. I think we're seeing the trend. I'm going to end it there. Thank you to everybody. And remember, these polls are anonymous. Nobody can see what you've answered. And thank you for all being truthful. Okay. So, of course, D was the red herring. And that we know. Okay. I'll put that in just to, okay, fine. But what about the others? Having sex without a condom, stress, eating unhealthily. Let's go backwards. Eating unhealthily, okay, a few people thought. So eating unhealthily, definitely we know it's not going to cause a viral load to go up. It's not going to cause a virus to remember that viral load going up means that the virus is replicating. We'll talk about that now. eating unhealthy is not going to do that. Stress, yeah, but the couple of people who answered it, I like what you're saying, okay, but it's not 100% true, right? Why? Because stress directly does not cause the viral load to go up. But of course, we know life is life. Stress causes us to do what? To stop taking our treatment. So of course, indirectly, yes, stress could cause a viral load to go up, but it's not direct. Okay, it's not if you're stressed, your viral load goes up. If you're stressed, you stop taking your treatment, viral load goes up. Okay, what about having sex without a condom? Now, 42% of people felt that. This is a wonderful myth. Okay, this is an amazing myth. It's been going. I don't know where it comes from. Okay, but of course, it's not true. Having sex without a condom is not going to cause the viral load to go up. The few viruses that are there, if the patient is suppressed, the few viruses that are there are going to be killed very easily by the ARVs that the person is on. If perhaps the person that you're having sex without a condom is on ARVs and has got a resistant virus because they're not taking the ARVs, they could pass on a resistant strain to you. And then, of course, the viral load will go up. But that's not because of having sex without a condom, but that's because of picking up a resistant virus, transmitted resistance. But just having sex without a condom does not push up the viral load. I've had nurses phone me on our helpline and say, the viral load's gone up, but I know why. It's because she's having sex without a condom. I said, no, that's not going to cause the viral load to go up. The viral load's not going up. I mean, she's either not taking a treatment or there's resistance. It's got nothing to do with having sex without a condom. But yes, of course, it's advisable to have sex with a condom, but it's not going to cause the treatment to fail. But thank you, everybody. I think it's a very, very interesting observation. Okay, let's see, there's a Q&A. Okay, so that's quite a complicated question. I think I'll answer that at the end, but it's a great question. Keep them coming. Oh, so there's another one as well. Okay, good. Yeah, we'll deal with that at the end. Perfect. Right, so when do we change our regimen? I'm not talking about when do we change the nappy, but when do we change the regimen? So in our national guidelines, it's a viral above 1,000 copies per ml. But certainly a patient who's with a viral between 50 and 1,000, we treat as aggressively as if they've got a viral above 1,000 copies per ml. In the Clinician Society guidelines and overseas, people are much more aggressive, and they would change the regimen with the viral load is above 50 copies per ml. And the reason is that in that gap between 50 and 1,000, what we call low-level viremia, okay, that there have been a couple of studies, not every study, but a couple of studies showing that those patients, adult patients, progress to treatment failure. I must say it doesn't happen in pediatrics. I've had kids with low-level viremia for years and years. And for that reason, people want to change. But I think certainly in our National Department of Health, we've got so many patients with viral loads above 1,000. Let's deal with that first before you worry about those between 15 and 1,000. Between 15 and 1,000, I'm not too worried. But yes, the guidelines, certainly the Clinician Society guidelines say change the regimen, and our national guidelines say you treat them as aggressively. In other words, you have to address adherence, repeat the viral in 3 months, just as you would with the viral above 1,000. The only difference is that you don't change the regimen if it stays between 15 and 1,000. We'll talk about it later on. I think certainly, I mean, there'd be a place to change, for example, from TE to TLD. I don't know if you call that changing the regimen. It is changing the regimen, but it's not necessarily because they are failing. But we'll talk about that later on. But that's important. Okay. So before you can understand treatment failure, you have to understand what is a viral load. And we all know, yes, viral load is a number of copies of HIV per milliliter of blood. But what is it really telling us? What does it mean to us? So to do that, I have to ask another poll. I haven't got too many polls, so don't worry. I think there's only one more after this one. So where is there a significant amount of HIV, more than 5%, found in the body? Would you say it's A, the blood, B, in the liver, C, in the lymph nodes, D, in the spleen? Also very interesting. I must tell you, if you've never been on this side of a pole, it's like a horse race. You see the bolt out of the gate and they're racing. It's just interesting to see who's going to win. Okay, we'll stop there. We've seen a very clear trend. Although, actually, a lot of you, 72% have voted already. Okay, I'm going to end it and share the results. Okay, so very interesting that 70% of you felt that HIV is found in the blood. Only 5% found in the liver, 36 felt in the lymph nodes, and 9% in the spleen. Very, very interesting. Let's see what's the answer. So where does this virus live? Where is there more than 5%? So does it live in the blood? No. Big surprise to 70% of you, right? The virus does not live in the blood. Okay, less than 5% of the HIV in the body is found in the bloodstream. So where is it found? In the lymph nodes? Some of you said yes, agreed. In the lymph nodes, in the liver, yes, and in the spleen. So in other words, you find it in the lymphoreticular system, the immune system. That's where you find it. That's because remember, we're going to find HIV in CD4 cells. And where do most of the CD4 cells live? They're in the reticular endothelial system. There's a small amount in the blood, yes. Okay. So you're not supposed to find HIV in the blood. So what does it mean if you're finding it in the blood? Okay, and this analogy, think of this poor young lady. It's probably not the most opportune slide to be showing after what happened in KZN a few weeks ago, but she's sitting in her lounge with water up to her ankles. Now, is there a problem in the lounge that there's water there? No. Most people don't have taps in the lounge or pipes in the lounge. So there's a problem somewhere else in the house, and water is flooding into her lounge. And it's the same thing with the viral load, right? There's not supposed to be virus in the blood. So if you're finding it in the blood, something's happening in the rest of the body that's causing it to flood or spill over into the bloodstream. So what could be happening that's causing the virus to spill over, to flood into the bloodstream? You guessed it, right? This virus is making billions and billions and billions of baby viruses, which then spills over into the bloodstream. So very important, viral load, a high viral load equals viral replication. The viral load is sky high. This virus is multiplying big time. The virus is 3,000 or 4,000, low but detectable viral load. It's multiplying slowly. And if it's an undetectable viral load, you could say it's not multiplying. It's not true because technically it's ticking over very slowly, but it's multiplying, replicating so slowly it doesn't spill over into the bloodstream. So that's an undetectable viral load. So viral load equals viral replication. Very important to understand that. So you can understand treatment. Lesego, if you can maybe just help Letena, struggling to see the slides, and maybe a question of just making the slides bigger, making me smaller. You don't want to see too much of me.
Yeah, the video. Okay.
Yeah. Okay, good. So viral load equals viral replication. Very, very important. Right. Now, a very important factor in managing patients with treatment failure is adherence. And why would that be? So let me ask you a question. I'm not going to do a poll. I could have done a poll, but I know you know the answers, right? How many tablets a day are patients taking in first line? And you all got it, right? 1 tablet a day. Good. Second line, you've got to add them up quickly, right? In the region of, depending on which regimen, between 3 and 6 tablets a day. Okay, at the moment, the dolutegravir, it's going to be AZT3TC and dolutegravir is AZT3TC is 2 tablets, 1 twice a day, dolutegravir is 3. And then, of course, you know, if they're going to be on a loperamide regimen, it's going to be 2 tablets twice a day, it's 4, plus if AZT3TC can be 6, right? So it could be up to 6 tablets a day, second line. And third line, well, it's getting better all the time, but in the region of 6 to 12 tablets a day. So can you see the problem? They can't manage first line. How are they going to manage second line? And how are they going to manage third line? And that's the problem. That's why adherence is absolutely key. And we need to address adherence. I will talk about that a bit later. Sometimes you have to manage the adherence before you change the regimen. And sometimes, believe it or not, you've got to change the regimen, manage adherence after you change the regimen. But I will go into detail about that. How much adherence do you need? Okay, now in the old days, we were told that you had to give patients to give 95% of their doses in order to suppress the viral load. That was based on a single study done with an unboosted protease inhibitor, which is not a very potent regimen, and you needed 95%. With our current regimens, it's more in the region of 80%. So which means if the patient, is taking 1 tablet a day, they can quite comfortably leave out 6 tablets a month. Okay, they've got to take 80% of their doses. But that doesn't mean you must tell the patients that, right? Because otherwise, what will they do? Well, they'll make sure they leave at 5. And then if they miss one dose, then it's 6. So you don't tell the patients you've got to take every single dose, but you only need to take 80%. So why am I telling you this? But just to explain that when we talk about adherence problems, we're not talking about the patient who misses the odd 1 or 2 doses. Okay. To be non-adherent, you've got to really make a good job of being non-adherent. Okay, so you've got to miss 80%, you've got to take less than 80% of doses in order for the regimen to fail. That's very important. But I say, please don't tell the patients that they must take 80%. We tell the patients they must take all their doses. And that's why if they do forget 1 or 2 or 3 or 4 or 5, okay, it's not going to be the end of the world. Right, now when I used to do this talk face-to-face, I used to ask about people's cell phones, but I can't do that now. So can you imagine a cell phone factory that is producing 10 billion phones every single day? That's about 1,500 phones a second, right? What are the chances? Imagine, as I'm talking, 1,500 phones, 1,500 phones, 1,500 phones. So what is the chances that at that speed, you are going to have every phone turning out to be a perfect phone? Well, clearly, it's not going to happen. There are going to be mistakes. And it's the same with this virus. The HIV virus produces 10 billion viruses every single day. And it's going to make mistakes. How often does it make a mistake? Literally every time it replicates. Every time it replicates, it makes a mistake. And we call those mistakes mutations. And the enzyme that converts the viral RNA to DNA, reverse transcriptase, doesn't have a proofreading mechanism, right? For proofreading mechanism, read spell checker. And you can see I needed a spell checker there. I've made a mistake there. So it's trying to make DNA, takes a nucleoside, adds it to the DNA chain, and then suddenly realizes, oops, I made a mistake. Can't say, come back, I made a mistake. It's too late. It goes through as a new mutation, a new virus, right? It's still an HIV virus. We call it a new quasi-species. And as I say, there are millions of these mutations formed every day, millions of these quasi-species formed every day. But if there are, and in fact, they say, the scientists tell us, and listen to this very carefully, that every day, in a patient who's not on ARVs, every day, the virus produces resistance mutations against every single drug. I'll say that again. Patient who's not on ARVs, every day, the virus produces resistance mutations against every single drug. And now I'm waiting for the Q&A to come. If that's the case, why do ARVs work? Because remember, these are mutations, they are mutants, they are crippled. They're not like the Teenage Mutant Ninja Turtles who are stronger. They are weaker, they replicate slower, right? So you've got this weak and crippled mutant. He hobbles over to a CD4 cell. By the time he gets there, there's 1,000 other viruses there before him. He doesn't get a chance to infect the CD4 cell. He just fizzles out and dies. So these mutations, in the absence of ARVs, these mutations are produced every day, but they can't compete with this unbelievable replication that's happening all the time. And so these mutations just fizzle out and die. But if the mutation should cause resistance to a drug, and the patient happens to be on that drug or that class of drug, it will suppress all the other viruses. And this weak and crippled mutation that replicates so slowly can take hold of the body. And that is how resistance develops. Okay, so if there's no ARVs around, mutations just fizzle out and die. But if the mutation causes resistance to a drug, then that quasi-species will continue to multiply while all the others are suppressed, and that causes outgrowth of the resistant drug. So let me show you in a series of beautiful cartoons that were produced by one of my colleagues from Right to Care, Dr. Julia Turner. And let me show you summarize exactly what I've just told you. So we need two things for resistance to develop. Number one is you need viral replication, meaning you need a detectable viral load. And number two, you need low levels of ARVs in the body. Okay. So let's look at three possibilities. First of all, let's take the patient who is not on ARVs at all, right? So what are we going to have there? But we said there's going to be unbelievable replication, 10 billion viruses produced every day. There's a mutation, there's a mutation. They can't keep up with this unbelievable replication, so you get lots of replication, but no resistance, because we said those mutations fizzle out and die. So in the absence of AOVs, lots of replication, but no resistance. Let's take the opposite end of the spectrum. Patient who's taking their AOVs perfectly, right? Someone's taking their AOVs every single day. So what's going to happen? Well, nothing. Why? Because the AOVs are going to work, no replication, and so no resistance. Okay, so the two ends of the spectrum, the one end, no AOVs, lots of replication, but no resistance. The other end, no replication, no resistance. But somewhere in the middle, where the patient's taking their medicines now and again, okay, where there is not enough AOVs to stop replications, you still have replication taking place, but there is enough to suppress all the susceptible viruses. That's when you get resistance. So let's look at the third case, where you've got low levels. So this is where there's AOVs, no replication, no resistance. Let's look at where you've got low levels of AOVs. So the low levels of AOVs are enough to suppress all the susceptible viruses, but not enough to stop replication. So you're going to get development of a resistant virus, which we said is going to happen anyway. And now, because all the other powerful viruses are suppressed by the low levels of ARVs, this weakened, crippled mutant can multiply, even though he replicates so slowly. It doesn't matter because there's no competition. And so he or she will replicate slowly, 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 but eventually start infecting other cells, and especially long-lived cells, and then live in the rest of the body for the rest of that patient's life. Okay, I lie, it's only for 75 years. I saw one study, 75 years. But for most patients, that resistance remains there for the rest of that patient's life. Okay, so we've got low levels of ARVs plus replicating virus, you're going to develop resistance. So that is how resistance develops. It's not that the poor adherence causes the resistance mutations. No, the resistance mutations are there anyway. It's a poor adherence that selects for those resistance mutations and allows them to grow out and infect all the cells of the body, and especially the long-lived cells. So that's how resistance develops. Okay, somebody else can't see the slides. Usually there's like a parallel line down the side. If you just click on that line and move it to the right or the left, you'll see somewhere. Otherwise, there's another way of seeing the slides. If you go to, I'm trying to think what it is. There's a yeah, you can see if you can help them. Thanks, Lucifer.
Okay.
It's just a question of change from presenter view to slide view or something like that. It's just a question of just. Okay. All right, good. So let's summarize. So how does resistance develop? It's when you've got low levels of ARVs, okay, plus viral replication. The low levels of ARVs suppress all the other susceptible viruses. And because there's replication taking place, you've got resistant mutations developing. And then what happens is that the resistant strain, because all the other susceptible viruses are suppressed, the resistant strain can grow out, even though he replicates very slowly, and can then replicate and take hold of the body. And that's how resistance develops. Okay, a bit more about resistance. Now, remember, the resistance test only tells about that particular regimen that is taking, because that's the ARVs that's going to suppress the virus, and so the resistant virus that's resistant to those ARVs is going to grow out. So a resistance test will only tell you about that regimen the patient is on. If you stop taking treatment, those mutations will disappear, okay, and the other virus will come up, and so the resistance is not going to be reliable anymore. But we said that resistance, once it's there, is long-lasting. Even though those mutations disappear, when you stop the drug, when you put them back on that class of drug, those mutations will come back up again. So the resistance is long-lasting. And because of that, you need to look at the patient's treatment history. You know, overseas, they do a baseline resistance test. They do it off the first line, the second line, the third line, the fourth line. You know, it's 7,000 Rand a shot. Yes, so then you just look at all the resistance and you can test and you can work out what the virus is resistant to. But in our situation, we're only doing resistance testing after our second line regimen. So you need to know that the mutation from the first line may not show in the resistance test because those mutations will have disappeared. So you have to take that into account. And, you know, certainly from the old non-nucleoside regimens are very easy to predict what sort of resistance we'd expect, but just take that into account. All right, I think this is our last poll. And this is one you've got to think a bit for this one. You see two patients in your clinic. One's got a viral load of 2,000. The other one's got a viral load of 200,000. Which one is the one more likely to have resistance? Of course, both could have resistance, for sure. But which one's more likely to have resistant virus? The one with the viral load of 2,000 or the viral load of 200,000? Somebody's asked about, does the NHLS lab do resistance testing? Very definitely. Absolutely, very, very definitely. There are criteria. We'll talk about when to do it. Don't just do it just willy-nilly, but I'm hoping at the end of today's talk, you will know when to do that resistance test. Okay, so it's neck and neck. I'm going to end the poll there now. Very, very interesting. Let me share the results with you. So it looks like the 200,000 is just winning, but not by much. And I think if I'd left it, only about 70% of you have participated. If I'd left it a bit longer, it might have changed. Okay, so remember the 200,000, we say viral load equals viral replication. So 200,000, that's a viral load, virus is replicating very, very rapidly. Okay, right. And a viral load of 2,000 is replicating very slowly. And what do we say about the resistant mutations? We say they generally replicate very slowly because they weaken mutant viruses. So a virus that is resistant to the ARVs is going to replicate. Yes, you'll have a viral load above 1,000, but it will replicate slowly. So you'll have a low but detectable. I must say, I also used to think must be 200,000 is where the resistance is, but in fact it's not. Okay, the one most likely to have resistance is the 2,000. I don't know, it doesn't make sense, but from what I'm explaining, it's a resistant, weakened, crippled virus. So it replicates very slowly. The patient with a viral load of 200,000 is not taking their treatment. So there's no, what they call drug pressure. So the virus, those active viruses that multiply very rapidly are multiplying. That's what's got such a high viral load of 200,000. The resistant mutants could still be there, but they're hiding away. They're called archived. They can't compete with all those viruses that are replicating so rapidly. Okay, but then when you put them on treatment, they take the treatment and you suppress those other active viruses, and then the weak and crippled ones come, but they replicate slowly. And so you're going to get a viral load of 2,000-3,000. Okay, so very, very important. Okay, so if you see a patient whose viral load goes from 1 million down to 3,000, you know, wow, that's fantastic. They've been taking their treatment. But you don't leave it at 3,000. You've got to make sure they're suppressed completely. If it stays at 3,000, that means what you've done is the patient was not adherent. Now they're taking the treatment. Now they're adherent. So those susceptible viruses have disappeared, but the weakened, crippled, resistant virus is remaining there. So yes, it's good that the viral load has come down from 1 million to 3,000, but you've got to make sure it goes back down below 1,000, in fact, below 50. And if it's not doing that, then there could still be resistance. Very, very important. Okay, I'm going to stop sharing now. Thank you. It was very interesting. Okay, so we did that. A few more principles of resistance. We said that the resistance is not created by the poor adherence, what we call the drug pressure. It's selected for by those the poor adherence, right? The mutations are produced anyway. But it's because the patient is not taking the treatment properly, that's what selects for those mutations which are there anyway. But once you've got a patient with resistance and you keep them on the same regimen, what's going to happen? You're going to get ongoing resistance. It's going to continue. We call it evolution of resistance, right? And that has 3 consequences. Number one, you get more resistance against that particular drug. Okay, if you do a resistance test, might say for a certain drug, low level resistance. But if you keep them on the same drug, you get more and more mutations, and you get intermediate and then high level resistance, and the drug's not going to work. So you get more resistance against that drug. Number two, you get what we call cross resistance against other drugs, usually in the same class, okay, which they're not even taking. So you're taking a certain drug, patients taking a certain drug, they get resistance against that drug, they get resistance against something else, even though they're not even taking it. That's cross resistance. And the third thing that you do from keeping the same family regimen, we said that these weakened mutant mutations are mutants replicate very slowly. So they don't do much damage to the immune system. But if you keep them on the failing regimen, they get what we call compensatory mutations, which strengthens up the virus and then causes it to replicate much faster. So then your viral load does go up. And of course, they do more damage to the immune system. So 3 reasons why you don't want to keep the patient on the same failing regimen. Number 1, you get more resistance against that drug. Number 2, you get cross resistance against other drugs they've never even been on. And number 3, you get compensatory mutations, which increase the viral load, okay, and cause this virus to damage the immune system more. So you don't want to keep patients, I've seen patients sitting on the same first-line regimen for 10 years or so. You don't want to do that. You don't want to do that. Okay. If you stop treatment, what's going to happen? So the resistant mutations will disappear, and they disappear at different rates depending on how much they weaken the virus. For example, the 3TC mutation, M184V, okay, don't worry about that, the name, we'll talk about it later on, weakens the virus profoundly. So if you stop taking 3TC, that mutation disappears very quickly. That's a bit like a car traveling down the highway at 10 k's an hour. Okay, 10 kilometers an hour, everybody's going to overtake it. No matter what speed they're going, they will overtake the car. So it's very easy for the wild type virus to overtake that resistant virus because this virus is replicating so slowly. But take another mutation like the K103N, which causes resistance against non-nucleosides. That hardly weakens the virus, one of the exceptions to the rule. So that virus is traveling at 110 kilometers an hour. So it's quite hard to overtake it. So often that mutation will persist for years and years and years because wild type, the other viruses haven't overtaken that resistant virus yet. So how quickly those mutations disappear depends on how profoundly they weaken the virus. Ones that weaken the virus the most, it disappears quickly when you stop it. Ones that weaken the virus less, takes longer and longer. Okay. We discussed that slide, we can move on. So resistance testing tells us some important things. And this is also, people struggle with this concept, so listen carefully. It tells us more which drugs not to use than which drugs to use. Okay? Remember, it excludes drug from a regimen. What do I mean by that? Let's say, remember the resistance testing will only tell you about the regimen that they're taking. Let's say a patient was on first line, TEE, tenofovir, ensifentrine, and efavirenz, failed it, got resistance, then went on to second line. So now the mutations from first line have disappeared. And now, when you test this patient after second line, do resistance testing, and you now find you do a resistance test, and it says they're susceptible to efavirenz. Does it mean efavirenz is going to work? No. Okay, because they're not on the efavirenz. So efavirenz may or may not work. We know probably it's not going to work. Okay, but if it says resistant to efavirenz, they find the efavirenz mutation, K103N, right? Is there definitely resistance? For sure. So if it says resistant to this virus, to this drug, we believe it. If it says susceptible to this drug, it may or may not be true because they have to be on that drug and taking it for the resistance test to show what's going on. Okay, so that's why it's good for telling you which drugs not to use, because if it says resistant, don't use these drugs, but which drugs to use, if it says susceptible, take it with a pinch of salt. It may or may not be true. Okay. And the reason is the resistance testing will only pick up resistance in viruses that are more than 20 to 30% of the total. So what if it's below, they call it a minor variant. So if there's, let's say only 5% of the viruses in the patient's blood are resistant, it will not pick it up. And that's why the patient has to be taking their treatment so that the percentage that's resistant is above that threshold of 20 to 30%. Only useful for the regimen that they're on, because if they're not on that regimen, then those mutations will disappear and remain hidden away. We call it archived. Right? If the patient's been adherent, you'll see those resistant mutations. If they stop their treatment and they're adherent, mutations will persist for about a month, but then they'll start to disappear at about the rate we said of, depending on how much they weaken the virus, so they vary in their rate of disappearing. A technical issue, the viral load must be above 1,000 copies per mol. Now, the NHLS, they've improved their testing so much that, in fact, they're now quite comfortable to say that the resistance testings, they are quite comfortable to test above 400 copies per mol. But sometimes you'll find, they might say failed to amplify, means the viral load was too low, they couldn't get it to amplify. It's difficult to interpret, and it's very expensive. I've got about and also it must be done correctly in order to interpret. I'll talk about that now. And I've written about 4,000. It's private at the moment. If you're doing the whole everything, reverse transcriptase, protease, and integrase, you're looking about 7,000 to 8,000 rand for a resistance test. So, yeah, you don't want to do it lightly. Right, now that I've spoken a bit about resistance, let's talk about our approach to a patient who is failing their ARVs. And there are three possibilities, right? Viral load is below 50, we call that suppressed viral load. Between 50 and 1,000, low level viremia, and above 1,000, we call that virological failure. Okay, so let's talk about a patient below 50. So what do we know? We say technically this virus is not replicating. We know it's ticking over slowly, but technically not replicating. Once the virus is suppressed, the immune system can recover, the patient's going to live a normal life. It's a great place to be. We also know that U equals U. I don't know if you've heard about it. The second, maybe at some stage you should have a talk on U equals U. Undetectable equals untransmittable, which means that it's been shown in really good studies that if a patient is taking their ARVs and the viral load is undetectable, below 50, in fact, in studies usually below 200, but we talk about below 50, then the risk of transmission to a sexual partner is zero. Not low, zero. There is no risk of transmission. And it's a big movement overseas and something that's starting here, but very important to explain to patients. Another reason why they need to take the treatment, because they cannot pass it on. You can even, if you've got a couple and you counsel them properly, they can, as a couple, decide we are not going to take treatment because I trust my partner to take the ARVs, and the other partner trusts the other partner not to go outside the relationship, pick up other bugs, which obviously condoms will prevent as well, and they can stop using condoms. You can't do sort of blanket things, no condoms, but in a individual couple situation, yes, that is an option that they can do. If they're a bit unhappy about that, no problem, use condoms, but they want to have a baby, they can just stop using condoms at the time the woman is ovulating and have a baby normally. So very, very important concept. Does U equals U apply to mother-child transmission? No. Okay, the risk is not zero, but it's very low. Okay, does it apply to finger sticks? No. Okay, we know that it's very low as well, but it's not zero, and I don't think anybody's going to test that. But certainly in sexual transmission, U equals U. It's absolute, one of the few absolutes in medicine. Okay, so what's your approach to the patient with the viral load is suppressed? We all want to kick them out, go, 6 months time. Wait a minute, not so fast. Why? Okay, how easy is it with a viral load that's high to get that patient to suppress? Not easy at all. Otherwise, I wouldn't be doing this talk. How easy it is for a patient whose viral load is suppressed to join the ranks of the unsuppressed? Very easy. Okay, so you don't just kick them out. You shower them with praise. I mean, I'm a pediatrician. I deal with adolescents, yes, especially adolescents, but even adults, okay, need a little bit of okay, so Anonymous, you asked the question of if the viral load is below 50, is the transmission still zero? I think I did answer that. It's not zero for needle sticks, but they've only been studied in sexual transmission. Okay, We know that PEP is pretty good, and that's probably pretty close to zero. People take the full course of post-exposure prophylaxis, but if the patient's viral load is undetectable, you should still go into post-exposure prophylaxis because it's not zero. Only it's been studied really in sexual transmission. Okay, right. So that's viral load below the 50. They're in a great place, but shower them with praise, encourage them, even have a look at the regimen. If they're on a complicated regimen, simplify the regimen. You'll see later on now, in many situations, you can change them to TLD, which is 1 tablet a day. Do that, make their life easier. Don't punish the patient, okay? We don't use our cell phone we had 10 years ago. We all got the latest upgraded version. So why must the patients stay on the same regimen they were on 10 years ago? Give them the latest upgraded version. So you can certainly simplify, improve matters, even if they are suppressed. You don't have to wait for them to fail. Okay, prevent them failing, keep them suppressed. Okay, low-level viremia we spoke about. We said in our setting, we would be aggressive about addressing adherence issues, but we would not change the regimen in the National Department of Health. In the private sector, you may be a bit more aggressive because the Clinician Society guidelines there say you would change. Not in every situation. What would a low-level viremia mean? Well, it could be a blip, what we call a viral blip. That's when the viral load goes back up and goes back down again with the next viral load. Number two could be persistent low-level viremia, where it stays low-level viremia. Jane, to answer your question, we do use 3TC monotherapy very occasionally these days because we have now got much better options to treat adolescents. Very occasionally you would use it, but it's not necessary nearly like we used to use before, only when you're like your back's against the wall. But today we have much better options than we had in those days. Okay, so low-level viremia can be a blip, it goes up, back down again. Persistent low-level viremia, it remains between 50 and 1,000, or early failure, right? The viral load is on the way up, and you just happen to take the viral load when it was between 50 and 1,000, but it's going to be above 1,000, or it could be just a break in adherence. So how do you tell the difference between these? Okay, you can't tell from this viral load between 50 and 1,000. You need to see what's the next viral load. If the next viral load is suppressed, well, it was a blip. If the next viral load stays between 50 and 1,000, it's persistent low-level viremia, and if it's above 1,000, it was early failure. So you can't tell about a virus between 50 and 1,000 on one viral load. You need the next one to tell you what that one was. Okay, and then viral failure, above 1,000, in broad categories, either means they're not taking the treatment, or there's resistance, or there's both. And under not taking your treatment, we include the other categories we spoke about drug interactions or malabsorption. That would fit into the non-adherence. We're getting low levels of ARVs, or resistance, the virus is multiplied, or both. They're not taking the treatment at the moment, but if they would take it, it wouldn't work because there's resistance. Okay, so that's your three viral loads, right? Suppressed, below 50, encourage them, praise them. Low-level viremia, you need to see what's going on. You need a second one to see which, is it a blip, is it persistent, or is it early failure? And above 1,000 is either there's adherence problems or resistance or both. Okay, so let's just talk about a blip. What is a blip? There's a viral load between 50 and 1,000 that then goes back down again. And what causes, remember I said to you, the virus is ticking over slowly. Okay, so I've been told that if you, let's say you decide, oh, I've got to grow some teeth here, I'm going to be a vampire. Okay, I'm not going to do one blood on my patient who comes in. So you've got a patient with suppressed viral load. He comes in 7 o'clock in the morning. You take his blood, he's about to get up. Not so fast. Sit down. I'm going to take blood again for you in 2 hours' time. 2 hours' time, you take his blood. Gets up. No, not so fast. 2 hours' time. You do 5 times. Take bloods 5 times in a suppressed viral load. They say that if you take blood 5 times during the day, the patient who's got a suppressed viral load, in one of those 5, you will find virus. Okay, because you get a little puff of replication every now and again, and so you'll pick it up on the viral load. So what a blip is just you happen to take blood in your 1 time a day in one of those times where there's a little puff, little burst of replication. It's of no consequence whatsoever, and the patient is not going to get resistance. So the treatment is still working. It's not going to affect the ARVs, doesn't cause resistance. But how do you know it was a blip? You can't tell from this one. You've got to repeat it in our guidelines in 3 months. And we see the next one is undetectable. Say, that was a blip. That was. Okay. So you have to address adherence as per the guideline and repeat the viral load in 3 months. And if it's a back and down again, that was a blip. Okay. Right. Let's focus obviously on a viral load above 1,000. And in private sector, this would be above 50 as well. So we said either they're not adherent, or they're resistant, or both. And under not adherent, we put any of the other causes where you get low levels of ARVs in the body. Okay, meaning they're not taking it, or they're malabsorption, or the drug interactions. Okay. Okay, I'm going to answer both of those questions in due course. All right.
Cool.
Right. So let's look at our approach to a viral load above 1,000. So what you want to do is, of course, in every case, you want to assess adherence. Okay. And assessing adherence is not like in the old days, patients failing, they go back to the counselors who start going through the same story they tell a new patient, what is HIV and why you got to take your treatment. Okay, this patient has been on ARVs. They've got issues with the ARVs. You have to deal with their issues, not tell them, it's so important to take your ARV. I know it's important, but I'm getting diarrhea every single day. You've got to find out what is the problem. It's not like a new patient. So you've got to have targeted, focused interventions, find out what is their problem and deal with their particular problem. Okay, maybe they're getting side effects. It may be that they're battling to take treatment in the morning because of a mad rush to get to work or to school. Whatever it is, you've got to deal with those particular problems, not just in general. You have to take your treatment because otherwise the virus, they know that. Okay, but you do need to obviously, so help them identify, address those barriers to adherence. You also want them to know why, what's going on, what a viral load is, what it means that the viral load is high, and why it's so important to get the viral load down. Then you repeat the viral load after 3 months. Okay, and in the DRH and in private, obviously you would have the same approach if the viral is above 50. Even though it may be a blip, doesn't matter, you still treat it the same, you do a targeted adherence intervention. And then in the DRH, we have got A, B, C, D, E, and in fact, Dr. Julie Turner adds an F onto that. Okay, so that's quite useful. A would be adherence. You have to go through these things. Factors may be affecting adherence, side effects, depression, alcohol, poor social structure, non-disclosure. B would be bugs, so they're getting other infections. They talk about TB and STI, but any infection, even a mild viral infection can drop your CD4 count and has been described to push up the viral load. I must say it happens less often that the viral load goes up with infections, but it is in the literature. C, correct dose, patients on the correct dose, especially pediatric patients. D, drug interactions, very important. We spoke about TB drugs, antacids, calcium, magnesium, zinc, which people are taking for COVID, not that it works, but they're taking all of those things. You need to find out from the history. E would be resistance. I'm sorry, I'll put in this one, and I can't spell, but we needed something for E, and resistance starts on R, so we went on the second letter. I apologize, it's me. I'll put that in there. So it's resistance. Okay, obviously then if you've excluded other causes and you suspect there may be resistance, you would think of resistance. And then Dr. Julia puts in F. What is F? Fertility. Why did she put in F for fertility? Well, if you've got a woman who is failing, you've got a high viral load, do you want her to fall pregnant? Clearly not. So you want to find out, is she on a contraceptive? And if she's not, she should be on a contraceptive until she's suppressed her viral load. Okay. And same goes obviously for men and for women too. They should use condoms at this time, okay, while the viral load is high until they are suppressed again, in which case then you applies and they can stop using condoms if they want to, or she can fall pregnant if she wants to. So very important that F as well. Okay, Tracy's got a good question. We'll address that later as well, Tracy. So in the Tracy's asked a good question. I can just mention, if you've got two low-level viremia, 450 and 400, would you change them to second line? So in the Department of Health at this point in time, no. Okay, in private, yes. But you're going to see, if you stay awake till the end of the talk, that there will be some situations where in the Department of Health, you will change into second line. So I'm sorry to give you such a cryptic answer, but invariably, you probably will change them based on the newest research, which we'll talk about later. All right. Okay, so now, so you've had a high viral load, you address adherence, you repeat the viral load 3 months later. Now your repeat viral load is still high. What do you do about that then? So now the repeat viral load is still high. It depends on what regimen they are changing. So your approach now diverges depending on what regimen, because you get two kinds of regimens. You get what we call a regimen that's got a low genetic barrier to resistance. So if you imagine this wall, little wall there, okay, is standing between the patient and resistance. And it's a very easy wall to just fall over. So that's very easy. One little mutation, they've got resistant virus. That's called a low genetic barrier to resistance. On the other hand, you get some drugs which have got what we call a high genetic barrier to resistance, a very high wall that's difficult to get over. And it takes several, 5, 6, 7, 8 mutations before they get resistance. That's a high genetic barrier to resistance. So if someone's failing a low genetic barrier drug, okay, by the time you do your viral load and repeat it 3 months later, okay, they will invariably have resistance already. Because, for example, efavirenz, we'll talk about now, within 2 to 4 weeks of non-adherence, you will have resistance. Okay. So your approach to that patient, very different patient who's got a high barrier where it takes ages to develop resistance. And if the viral load is high, it's high because they're not taking it, but the regimen would still work. So that's why you have a different approach depending on what regimen they are failing. So let's look at these drugs. Which ones have got a low genetic barrier to resistance? So, example, 3TC, although 3TC, it's a special case because the virus that's resistant to that, it confers quite a lot of advantages. And we often will keep using 3TC, even though it's resistant, because it keeps the weakened virus active, and it also partially reverses resistance to tenofovir, AZT, and stavudine. So we often will keep, but it only needs one mutation. But the non-nucleosides, one mutation for high resistance. For example, efavirenz, nevirapine, and raltegravir, which is an integrase inhibitor like dolutegravir, which you don't use much more. It's got a low barrier to resistance, also one mutation. But the problem with raltegravir, you get resistance to raltegravir, you can get cross-resistance to dolutegravir. So we want to try and avoid raltegravir for that purpose. So those are the drugs with a low genetic barrier. Which ones have got the high genetic barrier? Well, AZT D4T, not so much the back of it, need 3 to 4 mutations for high level resistance. And your boosted protease inhibitors up to 8 mutations. And dolutegravir, I've written so far no resistance. That's really in the situation of first line dolutegravir. In second line, we'll talk about you do get resistance. But in the first line, virtually no resistance. Okay, high genetic barrier to resistance. So our approach to a patient who's failing a regimen depends on the regimen that you are failing. Okay, Sergio will answer that one. Good. So patients failing a low genetic barrier resistant regimen, non-nucleoside, our old efavirenz regimen, TEE, or whatever other permutation. So what is the story with that? So there was a study done in patients in KZN who had 2 high viral loads on a non-nucleoside regimen. I should do a poll. What percentage of them had resistance to the regimen? 94%. So if you've got a patient with a high viral load, address adherence, repeat the viral load, it's still high, 94% of them will be resistant to that regimen. Okay. Because it's got a low genetic barrier and develops resistance very easily. So is there any point in continuing with a regimen that you know is not going to work? It's like giving them Smarties, Take your Smarties every day. Okay, I took my Smarties every day. Why is my viral load still high? I don't know, because I'm taking it every day, right? It's not going to work. The regimen is gone. The horse is dead. It's not going to ride again. So there's no point in keeping them on the same failing regimen if it's a non-nucleoside, because another regimen is gone. But yet we see this patient 10 years on the same failing regimen. It's gone. All you're going to do is get more and more resistance. There's no point in keeping them on the same failing regimen. So it's got a low genetic barrier to resistance. The virus, the repeat viral is above 1,000, you address adherence, and it's still high after 3 months, then what you do, this is hard for us, guys, hard. What you do, you change them to second line. Just like that. You're going to say, oh, what about the adherence? What about the adherence? Okay. No matter if you're giving them Smarties, you'll never know if they're taking the Smarties because the Smarties are not going to do anything. What you have to do is change their regimen, and then you hit them with adherence. Because then you'll see that they're taking the treatment, it's going to do something. But the regimen is gone, there's no point. So the second viral load is high, hard, I know. We struggle with it, right? Change the regimen, and then you hit them with adherence. Okay, because I've had patients that people consult me, I don't want to change now because they're not adherent, I haven't addressed adherence. It's not going to help. The regimen is gone. It's a low genetic barrier regimen. Change them to second line, and then you want to address adherence. And generally, we'll be putting those patients 2 NRTIs plus dolutegravir, okay, in certain situations, becoming less and less, 2 NRTIs plus a protease inhibitor. And we don't do resistance testing in our guidelines for patients failing a non-nucleoside regimen. We'll talk about it later on. Does it matter which NRTIs we use with our third drug? So we either change to dolutegravir, or we're going to change them to lopinavir or other protease inhibitors. So it doesn't matter which NRTIs we use. So it depends on what the third drug is. The third drug is a protease inhibitor. We haven't got much time now, so I don't want to spend too much time here. There was the earnest study, basically, and I haven't got time to go through in detail. We'll come back and do another talk on these studies. The earnest study basically showed that it made no difference if you've got 2 resistant NRTIs together with the active PI. So as long as the PI is active, you can use resistant NRTIs with it. And I frequently do that with my adolescent teenagers. They're on AZT3C, lopinavir, they can't take the twice a day AZT3C. I change to a once daily combination of NRTIs, a once daily PI, okay, and then often they will suppress. So the earnest study, and I'm not going to, for time, I'm not going to go into detail, showed that if you've got 2 resistant NRTIs, the regimen will still work. Okay. But what about if the third drug is dolutegravir? Okay. So we know first line dolutegravir, fantastic, phenomenal. Okay. It does beautifully, virtually no resistance. Third line is great because you're doing a resistance test and you put together a regimen based on your resistance test. But second line is, Joyce, the short answer is yes, but I'm going to answer that in detail now. Second line is problematic. Okay, raltegravir, no data, but it's a low genetic barrier and it's very risky. But what about dolutegravir? The problem is that dolutegravir monotherapy, you can get resistance. The dolutegravir monotherapy, you can get resistance. Okay, and there was a study called the Dawning study, which was patients failing, for example, an efavirenz regimen, and they compared them to dolutegravir with 2 NRTIs or lopinavir plus 2 NRTIs, but they did resistance testing and made sure they had an active NRTI, and they had phenomenal results. It was so good they discontinued the lopinavir arm. Okay, so the Dawning trial showing us that in patients who've got an active NRTI with dolutegravir, that you have a phenomenal result in second line. And that's why for a long time, we made sure that if patients on dolutegravir always had an active NRTI. But there have been new studies, and I haven't got time to go through in detail, new studies of which the most famous one, okay, there's the artist, there's the DEFT, and there's the Nadia, and there's the VCEND as well. But of the most famous one is Nadia, because Nadia has just published 2-3 weeks ago, has published their 96-week results. And here it is. I will copy and paste the link to the Nadia study in the chat, and you can look at it for yourself. But what the Nadia study was looking at, patients who were failing a dolutegravir or failing a tenofovir 3-TC in a non-nucleoside regimen, for example, TEE, and they randomized them to either get a dolutegravir regimen or a darunavir regimen. And then it was a once daily darunavir regimen. And then they further randomized to get either an AZT3-TC backbone or tenofovir 3-TC. So they were failing TEE. So if they got a tenofovir 3-TC, it was like basically keeping your backbone the same and just changing from efavirenz to darunavir or efavirenz to dolutegravir. Okay, we haven't got time, but the important thing is that that the 96-week results were that in those on dolutegravir, 90% had a viral load below 400, 87% in darunavir, and there's your p-value there, was non-inferior. So basically, a dolutegravir regimen in second line is as good as a darunavir regimen in second line. But then when they looked with those with no active NRTIs, responses were equally good. In those who went from TEE to TLD or tenofovir, lamivudine, and darunavir, you can see here that the viral load was below 400 in 92% in those in the tenofovir group, and only 85% in the AZT group, and not indicating non-inferiority, but in superiority. So in other words, a patient going from TEE to TLD had a better suppression rate than those who went from TE to AZT, 3TC, and dolutegravir. So what our guidelines are saying, AZT, 3TC, dolutegravir, so you have an active NRTI, the NADIA study is showing that no, in fact, TE to TLD is superior. Whether it is because of adherence, because the AZT is obviously a twice-a-day regimen, we don't know, but it doesn't matter. It's a very good, solid study showing us that TE to TLD is superior to TE to AZT, 3TC, and dolutegravir, what we call ZLD. And you can see your viral load rebound in 5.6% of those on tenofovir and 14% in those on zidovudine, and is your p-value 0.002. Okay, and also, although the numbers are small, there have been 9 patients with resistance. Okay, so the interesting thing is the darunavir group, 0 resistance. Dolutegravir group, 9 patients have got resistance. So dolutegravir is not as good as darunavir ritonavir. But of the 9 who had resistance, 3 went on to AZT, 3TC, dolutegravir. Okay, sorry. Of the 9 who had resistance, 6 went on to the AZT, 3TC, dolutegravir, and only 3 went on to the tenofovir TLD, tenofovir, lamivudine, dolutegravir. So it seems like that a patient failing TEE, it's preferable to go on to TLD, and you get less resistance as well. But you do get resistance. Okay, it's not like you get no resistance, like in with darunavir, ritonavir. You do get resistance, but less resistance if you're going. So this is changing everything. This is changing everything now. Okay, and the new guidelines are in the process of being published. In fact, the Clinician Society came up with a guideline last week. I don't know if I've got the link for that, but I'll try and find it for you quickly. And or at the end, I'll put that on for you as well. And so basically, what Nadia is telling us that we can use TLD after TEE. But after second line, other failures still need further discussion. The broader, the bigger guideline committee will come up with something on it. Also, to answer someone's question, if the viral is suppressed on a PI regimen, you could try TLD. Why is that? Because if it's suppressed on a PI regimen, remember, a suppressed viral load is very different from a high viral load. So if they're suppressed, it's also easier to keep them suppressed. But if they're unsuppressed on a PI regimen, you know the PI is active. So let's say you make a big mess and this doesn't work, well, you've got an active regimen to go back to. So that's why what this new guideline is saying is that patients who are on a TLD, on a TE regimen can go to TLD regardless of the viral load. You don't even have to do a viral load. You've got a patient in your clinic on TE, change them tomorrow to TLD. Nadia is supporting that. Don't even need to do a viral load. If they were suppressed on a protease inhibitor regimen, you can change it to TLD, because if you make a mess, you've got the protease inhibitor regimen to go back on, and it's a suppressed viral load, much easier to. In fact, some people say that you only really need 1 active drug to keep them suppressed. Whereas if they're high viral load, you need 2 active drugs. Okay, so that's what this new guideline is suggesting. The national guidelines are in the process of being produced now. The adolescents will be exactly the same, except also that on the back of a 3TC favorance regimen, they can go into TLD. And if they are children under from 20 to 35 kilos, if they're on if they're suppressed, you can change them to a back of a 3TC and dolutegravir. If they're not suppressed, you want to follow the guidelines. Okay. So we spoke about patients having a non-nucleoside regimen. We said they high viral load, repeat the viral load. If it's still high, change the regimen, and then address adherence. 2.5 hours plus dolutegravir is preferable. Otherwise, 2 hours is protein inhibitor. Nadi would say you could go from TE to TLD. All right, and we also said as long as the PI is, if you're going to go to a PI, as long as it's active, you don't have to worry about which drugs you use. That's patients failing a non-nucleoside, which has got a low genetic barrier. What about patients failing a PI or dolutegravir, which has got a high genetic barrier? So unless the patient has been on TB treatment, okay, with a PI, it takes a long time to develop resistance. You can see these are meta-analysis of a whole lot of studies. On the left, the y-axis proportion with a major PI mutation, on the right is time. And you can see that it remains at naught until virtually up to 2 years. So virtually no resistance in a PI until 2 years down the line. We suppose that the same would be with dolutegravir, although we don't have that kind of data yet. So the patient's failing a PI regimen, you have got this a wonderful 2-year window of opportunity. Why? Because we have this dilemma. Is it resistance or is it adherence or is it both? But for the first 2 years on a PI regimen, and we can say the same thing for dolutegravir regimen, the first 2 years, absolute clarity. What's your clarity? It's adherence. It's not resistance, because resistance will only come after 2 years. So as long as you do something in the first 2 years, you cleared, right? So you wait. Your first viral load is high at 6 months. Don't wait till 2 years down the line to do something. First viral load is high. Resolve adherence issues, whether it means simplifying the regimen. If it's a child on Kaletra, change them to lopinavir pellets or to tablets. If they're on twice daily and they're struggling, change to a once daily regimen. Okay. If they've got side effects, change the offending drug. Do what you can. Of course, address adherence, psychosocial, everything else. Supervised medication taking, especially with adolescents, but also with adults as well. Okay, and if it's a teenager, do disclosure as well. So what you can do to try and resolve adherence issues, you've got those 2 years to work on adherence issues. Okay, and at the end of those 2 years, if you still haven't got it right and you've had 3 high viral loads, then in our guidelines, you would do resistance testing. Okay. But you've got 2 years when you know clarity, it's pure adherence, resolve the adherence issues. Keep them the same regimen, resolve it. You don't have to stay, like if you decide to put a PI regimen and they've got diarrhea from their lopinavir, you can change to atazanavir, right? You don't have to stick with the lopinavir. If they're on a twice daily regimen with 83TC lopinavir ritonavir, you can change to once daily, put them on a backup of 3TC or tenofovir FTC plus either once daily lopinavir or change to atazanavir, which is once daily. You can change around in that class of drugs, but you're staying with the class of drugs, okay, to see if you can get them to suppress. Right, so we said you address adherence. If viral is still high after 2 years on a PI, we would then do resistance testing. If there's PI resistance, they need third line. There's no PI resistance, you would address adherence further. And the same would apply with the dolutegravir regimen. We don't have as much data, but it's very unlikely that they're going to be resistance as with the PIs. The exception would be drug interactions like TB treatment, or if they've been on raltegravir previously, then that would be a situation where you wouldn't wait your 2 years. But otherwise, your main focus can be on adherence. You've got 3 high viral loads and they've been on dolutegravir for 2 years, then you would change. You don't do resistance testing. If it's a first-line dolutegravir regimen in the DOH, in private you would. You change them to a PI regimen after they failed their first integrase. But if there are situations where you suspect there's resistance, for example, drug interactions, TB treatment, whatever it is, then don't wait your 2 years. You would do resistance testing whenever. Right, and that leads us to the indications for resistance testing. So in adults and adolescents in the DOH, any patient failing a PI regimen who's been on it for at least 2 years and has had at least 3 high viral loads above 1,000 in that time qualifies for resistance testing. If they're on a dolutegravir regimen, if it's a first-line regimen, we don't do resistance testing, but if it's a second-line regimen, same thing, 2 years if you've got 3 high viral loads. Okay, any patient who is on a PI or dolutegravir regimen and has been on TB treatment without correcting it for it properly, it was double dosing or using dolutegravir twice a day, then you do resistance testing. And any newly diagnosed patient who has been on PrEP in the last 6 months should have a baseline resistance test done. So that's indication we're doing resistance testing in the DOH. What about infants and children? Well, very similar if they're on a PI or dolutegravir regimen. So in the DOH, we do resistance testing on dolutegravir after 2 years. Okay, because the number of kids is much less, so they've allowed us to do resistance testing. So the 3-hour viral loads in a 2-year period on a PR dolutegravir, you do resistance testing. Any child who's got a high viral load, okay, who had on a PR or dolutegravir, who had TB treatment and it wasn't probably boosted, you do resistance testing not after 2 years, as soon as you discover that it's happened. And any newly diagnosed patient under 2 years of age, whose mom was on a PI regimen, and I think this will change to dolutegravir as well, who during pregnancy or breastfeeding, the child should get a baseline resistance test. Why? Because the children go onto a PI regimen at the moment, and so you want to find out if there is resistance there or not. How do we do resistance testing? So unfortunately, I don't have time to, I've got lovely slides to do this, but I'll have to skip it for another time. But basically, let me show you in this diagram. So you get what we call, you've got the resistant virus that replicates very slowly, okay, and then you've got your other virus, a wild type virus, replicates very rapidly. Now, wild type virus, okay, is the most aggressive of these other quasi-species, but a wild type virus really has got, the one thing about wild type virus is it's susceptible to all the ARVs. Susceptible to all the ARVs. So if the patient is taking their treatment, then wild type virus will be suppressed, the resistant viruses can multiply, and there's our cutoff, the dotted line. So you're going to find resistant virus above that line, you will pick up the resistance. But if the patient is non-adherent and not taking the treatment, then wild type virus replicates, and because it's replicating so rapidly, resistant virus disappears and hides away. And so above the line, all we've got is wild type virus, susceptible to all. You do resistance test will come back, susceptible to everything. All that's telling you is the patient is non-adherent. So in order to get an accurate resistance test, the patient has to be taking their treatment. Otherwise, you're going to miss it. You'll pick up the wild type virus and say susceptible to everything. It just means, doesn't mean it's susceptible, it just means patient's not taking the treatment. So how do you do a resistance test? You have to make sure the patient is taking the treatment. But the problem is that our patients all tell us, I'm taking my treatment, right? And I say, I'm going to do this test now, but it's only going to be accurate if you're taking your treatment every day. Are you taking treatment every day? What's he going to say? No, you know, doctor, I was actually lying before. I'm not taking my treatment. You're not going to catch them in a lie. So it doesn't help to do the resistance test then. What you need to do is you say to the patient, we're going to do this very expensive test. Very expensive test. Secha, you can answer that question as well. Very expensive test to see if the treatment is working or not, but it's only accurate if you take every dose for a month. So I know before you might have had problems, but what I'm asking you is just for the next month, take every single dose and then you do your resistance test. And I must say, since I've been doing that, I virtually never see a susceptible to all, which means it's a wild type virus, the patient not taking the treatment. Okay, so you don't do it straight away. Even though the guidelines say do resistance test, you say no. In a month's time, we're going to do resistance test, but I want you to take every dose from now until then. And if it's a teenager, get them supervised every dose and then do resistance test. That will then allow the ARVs on board to suppress the susceptible wild type viruses and allow the resistant virus to come up where it can be measured, and you'll get an accurate test. Okay, so they ask them to take the ARVs regularly for a month, then do your resistance testing. How do you interpret resistance testing? You see, you know, I run resistance workshops. We can discuss that there, but you've got to look at their treatment history. Mutations to previous ARVs will be archived, will be hidden away. They've got to be taken at the time of doing resistance testing. We've got there's a fancy database which we in our resistance workshops we go through with you people. We type in mutations in the database, and we generate a mutation, a result from the resistance test. The mutations come up with funny things like this, which looks like it's encoded. It is in code. It's a code. Basically, the number in the middle, 184, in this case, tells you where you'll find the mistake. The letter on the left tells you which amino acid is at position 184 in wild type virus, like in naturally occurring virus. And the V, the letter on the right, tells you what mistake the virus made. It took, instead of putting a methionine at position 184, put a valine. So that's what this mutation means. But we'll do our workshops, the resistance workshops. You're welcome to join, and we'll do that in more detail. And we type in these mutations in the Stanford database, and we come up with you can see it tells you high level resistance to atazanavir, low level to darunavir, lopinavir. So this is how we interpret the resistance testing. And then we change the ARVs accordingly. A few basic principles. We generally talk about we don't add one drug to a failing regimen. You want to change at least 2 drugs. But the Nadia study and the Ernest study showing that in that situation, if your third drug is a powerful drug like a protease inhibitor or like dolutegravir, that from TE to TLDs actually works. Okay, so it's turned itself a bit on its head. And preferably we said you want 2 new drugs, or 2 active drugs, but in certain situations when your third drug is a powerful drug with a high barrier, it may not be necessary, as we've learned. You want to get advice from experienced clinicians. As you can see, it is a complex field, and so you always want to get some advice. But if you do get advice, don't just do like what people used to do in the old days. Dear Leon, please help and send me a resistance test. Okay, we need to know details: the age of the patient, their full ARV history, previous regimens, because that won't show on today's resistance test. PMTC history if it's a mother or child, CD4 viral load, weight and height in children. Can they swallow big tablets in children? The resistance test results. Do they have something like TB, for example? Because we know that of our third line drugs, only one class that are compatible with TB treatment. So very important to know that as well. And right to care, we've got a form that people can fill in with all that information, and it makes it easier to ask your questions. If you're in the Department of Health, the NHLS have got this fantastic thing called HIV viral load result for action, where every week they will send out to you a list of all your patients with a high viral load. You subscribe to it, you can send for your clinic, for your district, for your province, for your country. They will send it to you. Because of POPI Act, they don't send you an email anymore, just an email with a link, and you've got to go onto the website. And it tells you which patients have got a high viral load. So it makes it easier for you to pull out those patients, chase them up, and deal with them. So to summarize, remember the new research, especially the Nadia study, showing that you can go literally from TE to TLD, amazing. And if you've got a patient who's got a suppressed viral load on a PI regimen, you can change to TLD as well. Okay, if they're failing a first-line non-nucleoside regimen, high viral load, resistant adherence, repeat the viral load, it's still above 1,000, you change them, and from our guideline, new guidelines, they're going to change them to TLD. Failing a PI or dolutegravir, we've got this 2-year window of opportunity to address adherence, where you know it's purely an adherence issue. You've sorted out adherence, and you've still got 3 high viral loads in that end of that 2-year period. Then in dolutegravir in adults, you change them to a PI regimen without doing resistance testing. In the PI, you do your resistance testing. And as we said from the Nadia, if they're suppressed on a PI regimen, you can change them to TLD. So that is our helplines. We've got an HIV helpline, both adult and pediatrics, 082-352-6642, and the TB helpline 063-698-6543. I will, while we are dealing with questions, I'll try and see if I can paste those links to the Nadia study. I've got the artist study there as well, and also our helpline poster as well. So thank you so much. I'm sorry I had to rush it, but I noticed I was going a bit over time. So we've still got a few minutes, Sergio, for some questions. I see you've answered most of them.
No, yes, the simple ones, Leon. I've left you with some questions that maybe needed
thanks.
your
Thanks.
attention.
Some of them I can see I can't
them.
answer. I'm gonna ask you to answer. But anyway, I'm quickly gonna pull up the
colleagues. Yeah. So thank you very much
links.
for attending. You may raise your hand as well if you would like to ask live questions. It's the right time to do that. Otherwise, we will go through questions that are in the chat. Please use the Q&A section for any questions. Otherwise, comments can be left in the chat. Dr. Leon, would you like to go through some of these questions?
Yeah, let's go through. Okay, so the first one I can see is we seem to experience unsuppressed viral load plus was previously suppressed to switched. So you talk about patients who switched to TLD from TEE. I must say we are seeing that. We are seeing that. We know from the Nadia study, it should be fine. The suppression rate should be good. And most likely it's an adherence issue. I think you've got to go look very carefully and see what is going on. Could it be maybe a side effect? You know, each drug's got their own side effects, something else, but we are seeing them. It's obviously not every patient. We're seeing the vast majority of patients are suppressing, but we are definitely seeing that. And you need to look into, especially look into adherence issues. And I think if they're not suppressing, you know, I would give them, follow the guidelines, give them 2 years, but if they're not suppressing, I would actually do resistance testing on those patients. Maybe even after a year in those situations, because they're really a second line. And in the guidelines, it says second line dolutegravir can get resistance testing, you know, at the advice of an expert. So I think definitely I would pursue that. But first look for adherence. That's going to be most likely. Even though they were suppressed before, things can change. The regimen's changed. There may be side effects. Their situation, life situation may have changed. So don't just assume that it's the regimen. Okay, it could very well just still be adherence. Okay, with low level viremia on Illuvia, after repeated viral monitoring, can you change to a dolutegravir regimen? So that's a difficult one. Okay, we don't know the answer to that. And I think the guideline committee is going to be addressing that. You know, at this point in time, certainly in pediatrics, we're saying if they've got a viral load above 50, you wouldn't keep the. Also remember that the Nadia is talking about going from TEE to TLD. It's not talking about a Bacova. So in pediatrics, you've got a patient on a Bacova 3TC and lopinavir. Can you change the Bacova 3TC to dolutegravir with a high viral load? We don't know. We suspect that actually you can't. Okay. So, but then you would rather go for AZT 3TC and dolutegravir in that situation. So it may be safer to go to AZT 3TC and Illuvia, but it depends on what they're on. But what I would do generally is I would, if it's low level viremia, you've got a good chance that that regimen is going to suppress. What I then do is I would then simplify. I would change to a once daily regimen, change the NRTIs to a once daily NRTI, change the lopinavir. You can give lopinavir once daily in that situation, or you can change to atazanavir, simplify the regimen. If you can get them to suppress, there's no question you can change them. So that's the easier answer. Rather try and get them to suppress, which should be quite easy if they've got low level viremia, and then it's quite easy. Otherwise, it's still a dodgy situation. We're not sure. Okay, resistance to the mother on second line. Right.
Yeah, I think that question is referring probably to the situation where the mother is failing, but the child's results are sensitive. Do you take the resistance results? Yeah, sure.
Right. So I think so. Remember, the earlier you do it on the child, the more accurate it's going to be. Because if you leave it longer, those mutations will disappear. But the child is different. You know, I mean, if the mom is non-adherent and she's passed on a resistant strain and she's not taking a PI at the moment, yeah, you may miss it. So it's not 100%. But certainly if you find the PI mutations, that's very helpful. If you don't find it, you would still then put them on a PI and watch carefully. If they're not suppressing, you know, then, you know, do something about it, and perhaps not wait the whole 2 years because you suspect there could be resistance. But you're quite correct. If you find mutations, it's very helpful. If you don't find mutations, it could just be the mom is not taking treatment at the moment, but she might have been taking it earlier when she passed on her resistant mutations to the child. So it's a very good point there, Joyce. Okay. Oh no, whenever Audrey asks questions, she always asks difficult ones. Okay.
But all in all, Leon, I've read it. She's referring to the requirement for
I know what you're saying. So it's a good question, Audrey. Audrey's a pharmacist from the Eastern Cape. And I'm pleased she's joined us, and we welcome pharmacists with a very, very important part of our team.
Yes.
So she's asking a brilliant question. She's saying, because of Nadia, right? Remember we said in the guidelines, said if patients on PrEP that you should do resistance testing before starting a regimen. Because of Nadia, can you not just give them TLD anyway? And I agree with it. I agree with it based on what Nadia is saying. Yeah, you should be able to give them TLD, and so maybe in the new guidelines they're going to change the need for that resistance test. Very, very important point, and great. Share the slides. We can make a plan. I don't know if I've got these slides, but I can pull up a link. I can put it on, see what we can do. Okay, how do we deal with atazanova side effects, especially abdominal pains? Okay, so remember atazanova, the main side effect really, the atazanova, it's very well tolerated. The main side effect is going to be unconjugated jaundice, which is not affecting the liver. Okay, it's just a it's completely, it's because it blocks a certain receptor. It's not at all affecting the liver. So it's very unusual to find side effects. So if you're getting a patient who's getting side effects with atazanova, so you need to, I think, look at each patient. Is it possible to change them to a dolutegravir regimen? I think that would be far superior. If you can't, and what we were doing in the old days, patients who had, for example, very high jaundice that was worrying the patient. If they've got jaundice and it doesn't worry them, you just keep them on it. But they get jaundice and it's worrying the patient, then most medical aids will allow them to go on to darunavir ritonavir. So that would be something you could do. But I would rather, phone us and we'll see if we can rather investigate if we can give this patient a dolutegravir regimen rather than staying with the PI. Okay. Why is darunavir the PI most frequently used in third-line regimens? Brilliant question. Because it's got the highest genetic barrier to resistance and the highest potency. It's really right up there. I've got a slide which I showed you, which shows potency versus genetic barrier, and darunavir is right up at the top. Okay, it's the most potent. It will work very often when you've got resistance to the other PIs like lopinavir, ritonavir, and atazanavir, ritonavir, and that's why it's used in third line. If there is darunavir resistance, you dose it at 600 milligrams twice a day. If there's no darunavir resistance, or using it as a second line drug, you can use it 800 milligrams plus 100 milligrams of ritonavir once a day. But if you've got darunavir resistance, then you've got 600 milligrams of darunavir and 100 milligrams of ritonavir. So that's why it's used, because it's the most potent of all the drugs with the highest genetic barrier. Good question. Many of our patients report poor compliance, not to being able to take the ARVs with food. Because they can't, is this people who've got food insecurity, who haven't got food. So most of our ARVs today can be taken with or without food. There are a few exceptions. Rilpivirine in the private sector has got to be taken with food, but otherwise there are a few exceptions. But even if a patient doesn't have to be taken with food, often it irritates their tummy more if they don't take it with food. So it's mostly you don't have to take it with food, and if they don't have food, it's usually fine, except for example rilpivirine. But often the patients feel better if they do take it with food. I hope that answers that. This question: a patient who is failing regimen 1T switched to a second line PI and was suppressed from the first viral load, and then the viral came up to 1,000, complained side effects of Illuvia. Okay, can you change to a second PI, even integrase? Okay, so remember we said you've got that 2-year window of opportunity where you just want to address adherence, and I just discussed this. For sure, I would change them. If they're getting side effects of Illuvia, you can change them to atazanavir, ritonavir, or even if that's not working, darunavir, ritonavir in the private sector. Yeah, for sure, you could. Could you even change them to a PI, to an integrase? Well, yeah, so this is what's going to be hotly debated by the guideline committee. If a patient is failing a PI regimen, can you go to TLD? And that we don't have good evidence for, because the NADIA study and the other studies are looking really only at patients failing a first-line regimen. So we don't know. I don't know what the guideline committee is going to come up with. At this point in time, it's probably safer if you are going to put them onto dolutegravir to make sure you've got an active NRTI. This is the kind of case I would discuss with an expert, but definitely within this 2-year period, it's purely adherence. You can certainly change them to a different protease inhibitor to make get out of your side effects. I think I did answer that in the talk as well.
Great stuff. Let's see if we can take a hand at NG Muchaki. Would you like to make a live comment or question, NG? Hi, NG. Your mic is unmute. CAZ, you disappeared. I thought you wanted to make a comment. Let's try.
Very often they just slips of the mouse.
Okay. Yeah, I think we don't have heads today. Kutele, do you have a question you want to ask? Kutele? Mieza?
Or
All
just
right.
type it into the Q&A.
No. I think Dr. Leon, I must really appreciate the presentation. I think it was very thorough. You took a very complex topic and you made it quite easy for us to really understand. I think we need to come back to talk about U is equals to U, because when you touch that topic, I saw some comments, people seem not to be very confident when to tell a patient that if you are suppressed, you are likely not to transmit the virus. So I really like that. And then, today, besides the clinical teachings, you had a lot of nice scenarios. Can you repeat what you said about a patient who needs to be changed? Is like a phone. We must give them a new upgrade. I don't know if you remember.
So I find that, for my sons, I'm advisor to one of the medical aids, and I find, especially in the private sector, where they will keep them on the same regimen that they've been on for the last 10 years, and they say, it's not broken, why must I fix it? But yes, they're driving the fanciest car, and they're using the latest model phone. Why can't you let your patients upgrade to a once a day regimen or one tablet a day? Why must they sit on a twice daily horrible regimen? You know what I'm saying? So just remember that. Just next time you see a patient, and you take out your fancy phone and you're putting them on keeping them on the terrible regimen because it works. Because the old phones still work.
That. Then there's a lot. Yes. Then the last one you said, when the horse is dead, it's dead. Please switch your patients. Can you emphasize that again? I really like
that. Absolutely. So the patient on a first-line non-nucleoside regimen, don't keep them on the same fatty regimen, okay? I know our inclination is we want to address adherence, and they're non-adherent. We know they're non-adherent, okay? But the horse is dead, okay? It's not going to work. It's like giving Smarties. What you do is you change the regimen, and then you hit them for adherence. Especially if you're going to go now to TLD, it's lovely. It's a 1 tablet a day instead of our previous 6 tablet twice a day regimen. Going to make a major difference, but then you want to hammer them with adherence. And just a quick comment, I think I agree with you that you need to have a talk on U equals U, but I can just quickly have a little comment on that. And also, I think maybe we need to come back, and especially hopefully we'll have new guidelines. The next time I come back, we can talk about the NADIA and the other studies and go through it in a bit more detail. But it's just very important. It's obviously it's just one component of treatment failure. But in terms of U equals U, I think it's very important you talk to your patients about U equals U. But the thing is, we can't just go and say to everybody, stop using condoms. It's got to be an individual couple thing. You've got to counsel the couple, and it's an individualized thing that couple must make a decision between themselves. You will facilitate the process, but they have to make that decision. Okay, but I think it's something definitely that we need to discuss and go into more detail. It's an amazing thing. We use a very powerful way of convincing them to take their treatment. Not only will you live a normal life, but you'll be able to, you won't pass on the virus to everybody else. So it's really a wonderful thing to do. And it's one of the few absolutes in medicine. I mean, how many absolutes have you got, where there's a 0 chance? It's 0. It's not low, it's 0. Obviously, only talking about sexual transmission. It's a wonderful concept, wonderful thing to discuss with every patient you see. Out of every patient of mine I saw a couple today, suppressed viral loads. I said, not only does it mean you're going to have a normal life, but when you get married, these are teenagers, when you get married one day, you won't pass it on to your wife, you won't pass it on to your children. Very, very important concept to discuss with our patients. And then in terms of, if they want to have children, you can discuss, there's obviously different levels of anxiety for the partner. Some may be happy with U equals U, some may not be happy with U equals U, but be happy just to stop using condoms when they want to fall pregnant. Others will insist on PrEP, and that's fine. It's not necessary, but you've got to individualize it for that. But there's lots to discuss, and I think it's a good topic for a future date.
Yes, let's try Dr. Femi as we are about to close. Dr. Femi, any comments? We want to hear at least 1 or 2 voices. Dr. Femi?
Yeah, thank you, Dr. Lesajo. Thanks, Dr. Leon, for the beautiful, insightful presentation. Now, I just want to add that today I did see a patient in one of our clinics who had been on a failing TEE regimen for almost 2 years. I was quite amazed when I audited the charts. And the reason they kept keeping the patient on that regimen was because they said they kind of suspect adherence issues.
Right.
So, but
right.
at least tonight you've clarified that definitely it already failed and they're still keeping, and the viral load keeps rising. And I told them it's high time this patient gets changed. So that kind of a patient needs to be moved on to, you say, moved on to TLD, or what's the next step? Because it's almost 2 years on TEE and there's a rise in viral load. Right. And they've just kept the patient there on that same regimen. Thank you.
For sure. So that's a patient failing. An excellent question. Thank you for that. And illustrating what I'm telling you is not. I'm not making this up. This is real. This is what happens. So it's a patient failing. Non-nucleoside regimen. You've got more than 2 high viral loads, so you change them straight away. And what the new guidelines are going to say, you'll change that patient to TLD as per the Nadia study. I think you're very justified to do that. Obviously, you still need to address adherence, but now you're giving them a regimen, a horse that is going to run, right? That they can ride this horse if they take it, but they still need to take it. So you still need to address adherence, but you change the regimen. You don't wait for them to resolve adherence issues because it's not going to happen. And often the efaviren's got so many side effects. They're not taking it because of the side effects, so you won't get them to take the dead horse anyway. So rather change them to a live horse. That will work, and that is much better tolerated. The second, I don't know, we're going a bit over time, but I saw there was 2 more questions. The one question was a patient, to summarize, who's a 16-year-old who's on a second-line regimen and got resistance to all the drugs. I'd like to see the resistance test, to see exactly what sort of resistance, but they changed to TLD and the patient now suppressed. Should they be worried? So no, I wouldn't be worried. I would just obviously watch them carefully. Remember, in the monotherapy, dolutegravir monotherapy studies, no one developed resistance before 6 months. So the resistance you have to follow them up for a good period of time before you can say you're not worried anymore. So I would do 3 months, 6 months, 9 months, a year. In the Nadia study, 2 of the patients with the resistance got the resistance after a year, but the rest all under a year. So it seems like if you can get them to a year, you're pretty safe in terms of developing dolutegravir resistance. But don't change the regimen, encourage adherence, and hope and pray that they stay suppressed. Otherwise, you're welcome to discuss the resistance with me, and I can see what we can help you with. But I think that's in certain situations, our third line, I'm on the third line committee, we do put patients who need third line onto TLD. But usually it's still, we're looking for an active NRTI with it in that situation. But if it's a first line failure, you don't need the active NRTI. TEE to TLD, no problem.
I don't know, it's talking about transition. I thought maybe you covered that.
I thought I covered that, yeah. So if they are failing a TEE regimen, you don't need viral suppression. You literally don't even need to do a viral load. If your patient's on TEE, you can change them tomorrow. You don't need it. But we're talking about on a protease inhibitor regimen. If it's a protease inhibitor regimen and they are suppressed, you can change to TLD. There's a chance it may not work, but at least you know you've got an active protease inhibitor regimen that will be able to be used. So that's why in that situation, where you've got a high viral load and they could have PI resistance and you mess up the dolutegravir, you've got nothing left. And that's why if they've got a high viral load and a PI regimen, you're a little bit more wary about going to TLD. But if they're suppressed, you can try TLD because a suppressed patient is easier to keep suppressed. And also you've got a viable option that the PI is still active.
Let's take Isaac's hand, and then this should be the last.
Okay, so Mervyn, maybe I must come back and talk to you about the fact in pediatrics of the new pediatric formulations. There are amazing pediatric formulations. It's a good hour's talk, so maybe Lesejo, you could book me for that as well. It's a good question. And Mervyn's question says, we already see dolutegravir resistance emerging in South Africa. Yes, I've certainly seen it, and we will see it because we know from Nadia there is resistance. But the vast majority of our patients are being suppressed, and we'll just deal with those few. We'll have to do surveillance and very carefully watch them. It's not like a PI, which you virtually don't get resistance. you get resistance with dolutegravir, but it's going to make life so much easier for so much more patients. And yes, there will be some that will have to deal with resistance.
Yep. Isaac, your last question or comment, and we close the session.
Okay, thank you, Doc. It's a comment.
Yes.
The Nadia study, some of us, I think we have already went through it unaware. Can I share maybe quick as testimony of what we experienced in our facility?
Okay.
We had this patient who was started on 2017. From 2019, he was having viral load unsuppressed. So ABCD was done. The patient was still not unsuppressed. Last year, the latest viral load was 500,000. We put the patient on TLD. Funny enough, after 3 months, the VL was 50. Now the patient is lower than detectable.
Brilliant,
Okay.
brilliant. And just remind me, which regimen were they on? Were they on TEE?
Yeah, they were on TE.
Right.
Okay.
So that supports Nadia. Brilliant. Absolutely.
Yeah.
In the old days, we would have said it's a bit dodgy, but now we've got very good science supporting what you're doing. Well done.
Yeah, even though according to Dr. Mawel is very clear, never changing a single drug on the failing regimen.
But
My
that's changed.
doc, I think we betrayed you on that. I think he's very strict on that. Never change a single drug on the failing
correction. He used to be very strict, but now we've got good science to show that he can change. Okay?
Yes,
he was quite correct. I did the same thing. I was exactly the same, but now you've got good science, which is telling you. So the second, we've got lots of things to talk to them about.
Okay, no, thank you very much.
Thank you.
Thank you.
Dr. Leon, thank you very much. We really appreciate this particular session. I think everyone is happy. They are still here. More than 300 people are still listening.